Hello everyone, welcome to this surgery class. Sorry for that slight delay. We had some technical glitches while connecting to the various platforms, but I am very happy the response from our students. So many students have joined our live class. Hopefully, we'll have a very useful and valuable session for you today. But today is a first class on surgery. I've selected the most important topic for you, that is trauma. Okay, if there are some example 10 questions are there from surgery, in that invariably 4 to 5 questions will be from trauma, this topic. That is the weightage of the topic. So I've selected this as a first topic so that we learn the most important one first, subsequently we go with the less important ones. So we'll start without any further ado. We'll start. Hopefully this is going to be a 4-hour class with breaks in between. I'll try to make as interactive, as lively as possible. Okay, in between we'll discuss some previous year MCQs and some interesting MCQs as well related to the topic. Uh, Hopefully it's not a traumatic day for you, traumatic evening. It will be a useful one. Only request from you is please be interactive. Okay, please putting your please keep putting your comments in the chat section there. Okay, if you have any doubts you can stop me then and there itself. We'll clarify that and then only we go to the next part. Okay, so this is a bit lengthy topic today, trauma. I'll try to cover the entire trauma along with the burns if possible today's session. So if you are okay, if you are ready, I let's start. Okay, so 2 3 basic principles of our class, surgery class. Going to be another 2 weeks will be surgery classes for you. So first thing, I will make it as simplified as possible. Surgery, I know it's not a main subject for you, mainstream subject for you, but still it's from exam point of view it's important. But I'll make it as simple as possible. Whichever is very much essential and relevant for your examination, only that will be discussed. I'll try to make the concept very crisp and clear. Okay, I'll not go into the details much and bore you. Instead, I'll make the concept whatever is required to understand that. I'll make it very crisp and concise. And all the PYQs included in my discussion. All the PYQs, whatever asked in so far, all included. If you, I can assure you 200%, that is, if you follow my notes, the class notes properly, each and everything and every question is included in that. I have not written in the question answer format, but each line is a question. That's the value of the class notes. If you write it down clearly, each point properly, each and every line is a question, and I'm very sure to keep revising the notes, you will be able to cover each and everything in your exam. Okay, so we'll try to keep it as interactive as possible, and if you have any doubts, we'll try to solve them then and there itself. Please ask it immediately. Okay, okay, fine. So trauma, uh, first let me ask you, what do you think is the most common cause of trauma? What is the most common cause of trauma? Anyone? Yes, please, I may give or may not give. Please don't depend on my notes. You have to write on your own. I'll go very slowly. Okay, and you have to write along with me. You have to write along with me because this notes is very very valuable. In the previous year, students also, if you can ask, okay, most of them found these notes very very valuable because class whatever you listen today we may forget tomorrow, but the class notes going to be permanent there with you. So you can like keep revising it as and when you want. So please write the notes. Mine is most of them, my concepts are I made it into flow chart wise. There is no writing paragraphs or big sentences. Everything is bullet points and flow charts. Everything is flow chart wise, so it will be very easy for you to revise and remember also. Each point is a question. Okay, so so yes, I am getting so many answers. Some people are right here. Who's that? Bhanushri is right. Gunjan Das. All of you are right. But to be more specific, okay, so the most common cause for trauma is emotional trauma, okay, more than road traffic accidents. Hope it's clear, okay. But in the exams, the option will be no emotional, but it will be RTA only. RTA is the most common cause, okay. Very good. Different teacher. Yeah, somebody asking, Ritik Tanwar is asking, notes you have of a different teacher. So see, the content remains the same. The teachers may be different, but the entire our presentation is different. Only we will try to make it as convenient as possible to you. So writing yet another notes is not of any waste. You can write along with me, okay? So that you'll be attentive in the class when you write along with me. If not everything, at least the important points, whatever I say, just note it down. Entire thing is not required. Listen to me. Along with that, whatever when I say this is important, please mark it. That's enough for you. Okay. Okay. That is about trauma, most common cause. What is polytrauma? If a patient has multiple injuries, then it's called polytrauma. I'm having injury to my hand, my leg also, my stomach also, then it's called polytrauma. What is multiple casualty and mass casualty? These are the wordings interchangeably used in your questions, your MCQs. These are the words, so you have to understand. Multiple casualty means 10 patients coming to you with a van fell down to the roadside, then 10 people come to you. You are sitting in a hospital, 10 people come to you. It's called multiple casualty, and you are able to manage the 10 patients. But just imagine you are sitting in a PHC, maybe in the taluk center or village center, and 25 people, some stampede happened in the in your the fair or somewhere, and 25 people come at once. You are one doctor there. Can you manage them? 25 people all at once? Not possible, right? It's called mass casualty. So hope you got the difference. Multiple casualty and mass casualty. Multiple means yes, there are more than 2 patients, 10 patient coming to you. You are not able to manage them with the facilities available. Not just you means not you. With the facilities available, you can manage them. It's called multiple casualty. Whereas mass casualty means you are not able to manage the patient. Even for a PHC, even 6 patients coming at a time is a mass casualty because you don't have enough facilities there, right? So if you're able to manage the facilities you have, it's called multiple casualty. If you're not able to manage, it's called mass casualty. Hope it's clear. Next, so you have a mass casualty or multiple casualty. So your one doctor, 2 doctors are there, some 2 nurses. So how do you go about? How do you manage this case? How do you go whom do you treat first? So there is a criteria called triage. You know, you should know this. Triage. Triage is nothing but prioritizing the treatment in the basis of severity of injury. Okay, prioritizing the patients with the severity of injury is called triage. The literal meaning of triage is to sort, to sort, to sort out. Means one by one you sort. It's called sorting, triaging. So how do you do this? How do you really do triaging? Okay, so you give tags. So you there are 10 patients. Go to each one and give him a tag. Give him or her with a tag. There are 4 types of tags. One is red tag, yellow tag, blue, green tag, and black tag. This also sometimes used, but we will not go into details. Okay, we use 4 types. That is red, RYGB. Remember as RYGB. Red, yellow, green, and black. RYGB. Remember, this is one important thing. So red refers to immediate life-threatening injuries. Immediate life-threatening injuries are called red tags ones. Okay. Yellow means they're not immediately life-threatening, but definitely they're life-threatening ones. Okay, you have some minutes to hours. Immediately means within seconds to minutes they will die. Okay. So whereas yellow means that's also severe, but not immediately life-threatening ones. Okay. Third thing is green. Green tag means they're injured, there is some fracture or something, they're injured or some bleeding is there, but they're able to walk on their own, or they're not very serious or severe injuries not there. That is green. Black means almost dying or pulseless, moribund patients are categorized. Even if you intervene also, the survival chances is very very less. Such patients are grouped into black category. Okay, black tags. So for red category ones, red tax patients, you have to immediately resuscitate and immediate intervention also required. Okay, whereas yellow one, immediate resuscitation is not required, but for after a red tags one, immediately you have to give attention to the yellow tag patients. Then you do the interventions. Green one you can do electively, even after 1 or 2 hours. If you do after even 1 day, if you do the fracture correction reduction and all, there is some wound, is there small wound, even if you suture it after 2-3 hours, nothing happens. Correct. So that's about green, and black ones will be disposed. Hope it's clear. Very important concept. One question will be there from this triage concept or the tax ones. So please know this very well. Next, how do any casualty patient or trauma patient comes, what you do is, this process of entire thing managing is called SALT. You remember the mnemonic SALT, SALT. S for sorting out the patient. That's what triage we did. By triaging, we sort out the patient who require the treatment first, then who requires all those things. That's sorting out. After that, after sorting out, assess individual patients. Assessment of individual patient. Then after assessing, give life saving treatment. What is the life saving treatment is there, that you give first. Okay, whatever the life saving treatment you give first. No need to give definitive or like a complete treatment. Only life saving treatment. For example, if there is a bleeding is there, stop the bleeding. That's a life saving one. You're not going to do the definitive treatment then and there itself. Okay, whatever the fracture is there, all those things, not going to do then and there itself. Then if you have a facility, you can do it then it's there itself in your hospital. Or if you don't have enough facilities, you are in a remote area, transport the patient to the tertiary care hospital where all the facilities are available for the definitive treatment. While transporting or while shifting from one place to another, what we follow is missed protocol. Missed protocol. For example, I am there in the tertiary care hospital, and you are my junior doctors in the Taluk health center or the primary health care center. You bring me the patient from a PHC. One patient is there. You bring me, and you give me the handover the doctor in the tertiary care center under these headings called missed protocol. Again, one is SALT. You remember SALT. Another is missed protocol. Missed protocol, remember. M stands for mechanism of injury, how the injury happened, mechanism of injury. I stands for what are the different injuries sustained. Patient is having a laceration in the head, sir. I have done the suturing. Then patient is also had one fracture in the left upper limb. Patient is also having a patella injury, like that. What are the injuries sustained? Then what are the signs and symptoms with which patient presented? Patient was having tachypnea when he came, or patient is having a bluish discoloration of the lips. Whatever the signs and symptoms. Okay, patient was bleeding from the neck. What are the signs and symptoms were there? You will explain. Then fourth, what are the treatment you have already given? What are the first aid? What are the initial treatment you have given? I have given the tetanus toxoid injection, and also for analgesics I have given a diclofenac injection. I have given a dose of antibiotic. I have given tranexamic acid to stop the bleeding. All those first aid whatever you have given, you can explain. And then how did you transport the patient? That's also very important. How do you really carry out the patient from one place to another? So these are the four headings under which you explain the what had happened about the patient to the consultant there. It is called missed protocol. Remember, important. Then first R. Anyone? What is the importance of first hour in trauma? First hour means now the accident has happened. Next 1 hour from 5:55 to 6:55. That's 1 hour is called golden hour in trauma. Very very important. Okay, Very important. They may confuse you with some other questions. Golden hour for wounds is 6 hours. Okay. This is golden hour in trauma. For example, there is head injury is there. Okay, very good. Golden period, golden hour, very good. Aparajita, Vishwa, very good. Nikhil, very good, excellent. This is called, because any patient comes at the earliest, you can correctly diagnose and do the needful at the earliest. Chances of survival is more. Okay, but any patient if you bring very late, then the chance of survival is less. That's why first hour in trauma is considered as the golden hour. Remember, again a PYQ, previous yearly asked question. Okay, so next, yes, coming to the most important topic of today's discussion, that is ATLS protocol. ATLS protocol. Okay, you should know this. See, it's not about the which branch you are in, which department, or what you dental you do, or Ayurveda, whatever we do. Okay, whichever doctor we are. But one thing what we should know is trauma, because see, you are in a hospital. For example, you are a PG next year. You are going to be a PG in a government hospital. In government hospital, how you know the emergency is managed by multiple PGs. All the department one PG will be there, including from the dental, from the OBG, from the orthopedics, from the surgery, everything. You are also there. One of you, our Chirag and Sakshi, they are the two PGs sitting in the emergency today night. And suddenly one patient comes. With a trauma. Your surgery friend has gone to the ward to see a patient to do checkup for the tomorrow's operation. Some orthopedics and OBG friends have gone for a cup of coffee, and nobody is there. Only pediatric friend and you are there. For a dental surgeon and one pediatrician is there. So only two people, and trauma patient has come. Now you can't tell. That I'm a dental doctor. I don't know what to do or how to do. I will not see the patient. No, you're a doctor. You should be seeing, at least doing the first aid to that patient. Okay, so that's why I say, please, this is not just for exam purpose, for your life. You know basics of trauma management, and our trauma management guidelines. Everything comes from ATLS. Okay, so ATLS protocol. In that we have certain guidelines. As soon as a patient comes, first thing what we do after I told you sorting, assessment, okay, and doing the initial treatment, then the definitive treatment. In that, in assessment, salt is there, no salt. That salt assess. Assessment. How do you do the assessment? In assessment, after doing the triage, you assess individual patients. First, what is called primary survey. You do what's called primary survey. Then you do secondary survey. Primary survey refers to the initial quick examination. Quickly, you will not do everything in detail. Quickly, you will assess there are certain things what I'll do. I'll tell you that you do very quickly within the seconds to minutes. After doing all the primary survey, then only you go to the secondary survey. That is detailed or elaborative head-to-toe examination. Everything you will check. In primary survey, you will check only for 5 things: airway, A, B, C, D, E. Airway, breathing, circulation, disability, and exposure. So the A, B, C, D, remember, A, B, C, D of primary survey. Airway, what's the trick here is, you will remember only A for airway. But the trick here is, it also includes another equally important component. That is, A is not just airway. A is, remember, the second part is also equally important, and all the questions are based on that. All your exam questions are based on mainly on that, because examiners know you will miss that part while reading or while studying. So the second part is, along with airway, securing airway or maintaining the airway, you should also do restriction of the cervical spine movement. Very good, HS. Spine protection, excellent. You're right. Okay, so you should do airway, very very important. All the questions I'll write and give today itself. One question will be based on this cervical spine protection or airway only. In the trauma portion, mainly for you, what they ask is this airway protection only. Okay, so remember this airway, along with that cervical spine also has to be movement has to be protected. Then B for breathing. How is the patient's breathing pattern? You have to check, and in that mainly whether ventilation, oxygen inhaling outside, okay, and oxygenation, whether the patient is getting enough oxygen or not. Two things has to be checked. C for circulation. Circulation is whether the blood circulation is happening adequately or not. That you will check. Along with that, you do hemorrhage control also. Bleeding control is here, not the first one. In your college or somewhere when you might have learned first bleeding control. No, along as per the ATLS protocol, bleeding control is third. After airway breathing, then only comes the hemorrhage control. One more protocol is there, E EABCD. In that, E for control of exsanguinating bleeding. E also called, it's called C also, CABCD or EABCD. In that, bleeding control is first. That's only in UK. UK they follow this protocol. EABs, don't get confused. But we Indians, we follow ATLS protocol. So in Indian scenario or any questions in our Indian exams, you write as per the ATLS protocol only, not EABCD. In that, bleeding control is the first. But see, you use the logic. Blood 5 liters are there. Even if you bleeds for some time, you can manage later by giving some blood or so. Okay, even for the bleeding for 5 liters to occur, it will take long time. Okay, if there is small bleeding here, it will be continuous bleeding. You will have some 2-3 minutes or 5 minutes time. You need not have to do immediately. But please, all of you, how many? There are more than 300 students here. Do one thing. Please take your hand and close your nose for 30 seconds. Is it possible for you to keep your nose or airway closed for 30 seconds? Not possible, right? That's the importance of airway. Airway has to be patent all the time. Even if it's not patent for a minute, patient may die. But bleeding, nobody will die immediately. It will take time. Understood? No? This concept has to be very, very clear. They try to distract you like that only. Patient is having severe bleeding from the thigh and patient is also dyspneic. So what you will do first? So the option will be bleeding control, suturing, all those options will be there. But your answer should be first securing the airway. This will be the question. I'll come up with so many examples at the end of the class. Then you will understand how the questions will be asked and how to answer them. But now remember, A for airway with cervical spine movement. Why this is important? Because many patient, any trauma, they sustain injury to the neck. If they sustain injury to nerve, injury to the neck, spine will be involved. That will be not evident from outside. Patient also can't tell. If you try to move the patient or do something maneuvers, no, that injury may get aggravated and patient may suddenly die out of spinal shock. Spinal shock is very, very dangerous. Patient may immediately die. That's why protection of the cervical spine is important. You don't know whether it's injured or not unless you do some test. So for now, you consider a patient is having, all the patient with trauma is, you consider they have cervical injury. Protect it first. Okay, protect it first, then only do the other things. Okay, that's why somebody asked why. So it's important to restrict cervical spine movement because okay, now what happens is airway is blocked. Now you want to secure the airway. While moving for the airway, you may put the pressure over the cervical spine and that will aggravate the cervical spine injury and can cause irreversible nerve damages or can cause spinal shock. That's why Aditi, no, so who asked that question? Banushri, hope it's clear now. If you are clear, please give a thumbs up. If you still not understood, ask me again. I'll tell again once again. Okay. Aditi Agarwal is asking, sir, in exsanguinating bleeding, what to do? Yeah, see, protocol wise, if one doctor is there, you do the same A, B, C, D, E. First airway, then breathing, then only control the bleeding. But in practical, what happens? You know, in the hospital, Aditi is a doctor in the emergency, in Mumbai, in a big hospital. What happens is, although we brought, there are 2-3 people will be there managing one patient. So one will be invariably put a pressure over the bleeding side. Another will be so need not have to worry. There is a bleeding also. Another nurse, if you tell someone, please keep some pressure over that area. Meanwhile, I'll do the primary survey with airway, breathing, circulation, and all. That's what happens. Aditi, don't worry. Okay, nothing will happen. Patient will never die because of the external bleeding. There's some internal bleeding which go unnoticed, patient may die. That too not within the seconds or minutes. It will take time. But patient can die within seconds or minutes if you don't address to airway and breathing. I told you, explained you how. The patient airways nose is blocked or my pharynx is blocked for 30 seconds. I can't take air inside. Collapse within 30 seconds, 1 minute or 2 minutes. There's no oxygen inside my body. Hope it's clear. Hope the importance. What if there is extreme external bleeding? Divij, I just answered your question also. In exam, we will know they are asking CD or no, Aparajita. It's always ABCDE only. They can't ask questions as per the EABCD. ATLS only. I told you, no, in India we follow ATLS. So Indian questions should be as per ABCD protocol only. ATLS. Yes, Kirti is right. It's cause spinal injury can cause permanent paralysis. Apuro is also right, telling spinal shock. Good. And why different in protocol India and UK? Sloran is asking. Yes, we in this all the health, all the guidelines, protocols, we follow America. Okay, UK, just like American English and UK English. There's a slight difference. Similarly, protocols, EHS, European Society, they have separate guidelines. Different have societies or different countries have got their own guidelines or studies. We follow US one mainly, most of the things. I hope it's clear. But see, this is just protocol. But in the practical, in the reality, what happens is there are 2-3 doctors or that emergency team is there. No, they will manage all the things simultaneously. 2-3 people will hold the cervical spines. One will check the airway. One will stop the bleeding. So you don't worry. Don't get panicked. What will happen and all. So this is just a protocol. Know this. Okay. And somebody is bleeding profusely from carotid. What will we do in the airway? See, carotid it's outside. Carotid is here in the neck. Okay, but airways you see in the nose and the mouth. You can do that. Okay, you can press keep a pressure over the carotid and you can still examine. No problem. What is the any other doubts? Any other doubts? Any doubts? You please till so far. Any doubts? You please ask me. Also, no. Okay. Sorry, got a hospital call. Okay. What's that next? Okay, Subiksha is asking, what is platinum period? What is platinum period in trauma? Trauma means, see, there is nothing like a particular time as such. Initial 10 to 15 minutes, it can be called platinum period. But first hour is called golden hour. Platinum is first 10 to 15 minutes. 10 minutes you can consider it as, okay. Then spinal shock, please treat cervical spine part. Okay. Cervical spine. We are going to see, this is just now I'm telling, we'll go into the details after this, okay. That is asking, we'll go into details. What is the full form of? Harita is asking ATLS, Advanced Trauma Life Support. Advanced Trauma Life Support is ATLS. Okay, ATLS means just important. Good that she asked. Advanced. BCLS means basic life support. BLS means basic life support. ATLS means Advanced Trauma Life. Okay. ACLS, Advanced Cardiac Life Support, like that. Okay, you have so many things. Okay, spinal shock, but sir, excessive blood loss leads to hypovolemic shock. Yes, Harshita, if there's hypovolemic shock, you can treat it, right? See, you're right. Harshita is asking, excessive blood loss will be there, hypovolemic shock. Shock, you can give some fluids in the C. After A, B, C, you do resuscitation with the fluids, or you can give blood and you can still resuscitate. But airway is stopped, and how much of blood you give, what's the use? Patient is already dead. Okay, I will go into details and we will give some example, you'll understand. That advanced trauma already answered. Akanksha has already answered. Good. Color coding. All good. All no problem. Color coding, I told you already. Red for immediately life threatening, and uh, yellow for not immediately life threatening, but still it's life threatening, dangerous. Third thing is green. Green means walking injured, means he's having some injury but he's stable. Fourth is moribund pulseless, means about to die patient. Hope it's clear. We'll go a little faster because so much to cover today. B for breathing, in that ventilation and oxygenation we'll see. C for circulation and hemorrhage control. D for disability, mainly any neurological disabilities are there. C. E for exposure, we'll expose the patient completely and we'll see if there are any other injuries or anything. Okay, that's A, B, C, D, E. Now this is the one thing, one question they can not directly as such, you should know. What are the immediately life-threatening conditions? There are 6 named or for your information, 6 immediately life-threatening conditions are there. First is airway obstruction. Any foreign body, anything obstructing my airway, the nose or my oral cavity or pharynx, anywhere in the airway. Okay, from the nose till the bronchioles, anywhere there is a block, it can cause airway obstruction, and it can, I told you, it can immediately cause death. Next, tracheobronchial injury. There is no obstruction, but there is a cut. My trachea is cut already. See, trachea is like this, it's cut. So air cannot go into the lungs now. Air cannot enter. Correct? That's why tracheobronchial injury. My bronchus is cut or anywhere. Trachea, bronchus, anywhere there is a injury is there. Air leak is happening. Air is not going to the lungs. Instead, it's leaking. Then also it's a life-threatening. So these two, how you can remember is first two, airway obstruction and tracheobronchial injury. They are belong to airway. In mainly when you check for assess for airway, you check for these two. Is there any airway obstruction or any signs of tracheobronchial injury? Next two things are pneumothorax. What do you understand by pneumothorax? Tell me. Pneumo means what? Pneumo means air. Thorax means the thoracic cavity or the lungs. So inside the pleura, there is air collection is there, called pneumothorax. I'll explain to the what is pneumothorax under later. Just know for now the two types of, there are three types, but the two types are immediately life threatening, that is tension pneumothorax and open pneumothorax. These two conditions belong to breathing. Lungs, there is a problem in the lungs, so breathing, air in the pleural cavity. Apurva is correct, Tanvi is also right, there will be breathing problem, correct, these two. Next you have massive hemothorax. Hemo means blood collection in the pleura is called hemothorax. Massive means entire pleura is covered with blood. Okay, and cardiac tamponade. Tampoon means what? Pressure. Cardiac tamponade. Heart is beating like this inside a chamber. What is the chamber? Just like pleura is covering the lungs, heart is also covered by a membrane. What is that? What is that membrane covering the heart is called? Pericardium. Just like pleura, just abdomen is covered by peritoneum, heart is covered by pericardium, lungs covered by pleura. Okay, so there is a, in between the heart and the pericardium there is a blood. There is an injury to the heart. Okay, there is a bleeding from the heart, so it accumulates in that cavity. So when the blood accumulates in the cavity, heart cannot beat, heart cannot contract or relax. So heart is stuck like this, it cannot beat. The heart doesn't beat, what happens? There is no blood circulation, blood output. There's a problem with the circulation. There is no blood output. Understood? So cardiac tamponade. We'll go into the details of each. Okay, don't worry. Now, for now, you remember there are two conditions from in airway can be fatal or immediate life-threatening. The two conditions in breathing like pneumothorax, and two conditions in circulation which can be immediately life-threatening. Remember, it's easy to remember if you remember like this. Okay, in many questions, this not directly they will not tell there is a massive hemothorax and all. They'll give what are the signs and symptoms of massive hemothorax. Then they'll try to elicit from you what is the immediate line of management. Okay. Okay. Now we'll go. I told you my class will be most of the concept I'll explain with what is that flow charts, so that you can imagine yourself in a hospital or in the casualty or in any concept, surgery concept for that matter. I'll explain with flow chart so that you can go step by step, and many questions will be asked manner that what is the immediate next step you do. What is in surgery? if the patient comes with abdominal trauma, what is the immediate next step you do? So I can't make you answer each and every point or each question. If you go through my flow chart or if you go through my notes, na, all the answers you will get by yourself. I will not feed you fish. Instead, I'll teach you fishing. I'll teach you fishing so that you can catch how much of fish you want, whatever you want, you can do that. You will not dependent on a particular class or particular notes or anything. You will know how to answer any type of questions. So first thing, any trauma has happened now. For the doctor or a patient has come to the casualty for the resident doctor there. What you'll do? First thing, first and foremost, see, there's a rule. Before saving others, first you have to safeguard yourself. Scene safety. There is one patient has come along with whom there are 10 patients attenders who are mongering there all around. Can you do anything properly without fear or without any obstruction? No. So first, scene safety. Make the scene clear. First, let all the persons go away. Only patient is lying down there. Then you can start whatever it is. Then the next step is check response. Patient is lying without any response on the ground. You go there and knock his shoulder or chest like this. Hello, hello, are you there? Are you there? Are you okay? Okay. The patient is not responding, then fine. Patient is responding, okay, I'm having little pain, okay. Then nothing to worry. There's no emergency as such. No, the patient is not responding at all. Patient not giving any reply to you. No, then immediately call for the help. Tell someone who is surrounding there. Okay, please call ambulance. Please call the ambulance. Okay, or call the doctor, whatever it is. Call for help. Then again start talking to the pinch him or do something to try to talk to the patient. Try to talk to the patient. If the patient is talking, that means what? Patient is able to see. I'm talking means what? My airway is intact. That's why I'm able to talk. My vocal cords, airway. Vocal cords is within the airway, no? When the air moves, there's a sound is produced. If I'm talking means my airway is patent. Airway is patent, applying a cervical collar. You might have seen, no? While going on the roads and all, many people while riding the two-wheelers, they'll be wearing one collar like this. That's called cervical collar, mainly for spondylosis and all. I'll show you the photo later. You put that. So A is done. Airway assessment is done. That appears to be normal. And your second thing is cervical spine movement restriction. That's also done by putting the cervical collar. Okay. So A is done. Next you go to the B. That's breathing. Okay. So that's one part of the flow chart. Second part, if the patient is not responding or not talking, then you even for pinch or you shake him, whatever you do, patient is not talking. Instead, there are some signs. There are some signs like patient is having tachypnea, means patient is having rigorous breathing, increased level of breathing, and using accessory muscles for respiration. Accessory muscles means mainly the sternocleidomastoid muscles and intercostal muscles. When the patient is breathing, now this intercostal or sternocleidomastoid muscles are getting involved. That means he's struggling to breathe. Or patient is having any. You are not audible. I think I was here. The network is good. All of you having this problem or not able to hear? I think from my side, the network, Wi-Fi, everything's okay. It's for the everyone or yes? I think you have to refresh. Am I audible now clearly? All okay, it seems. Okay. Okay now. You're audible. Okay, fine. I'll again explain anyway. Don't worry. Those who missed, I'll again explain. Okay. So first thing is scene safety. I was telling scene safety. So your patient is lying on the road. Okay. You have to clear. You can't do anything on the road. You have to bring him to the side. Or for example, patient is drowning, you can't do anything in the seashore or anything, you have to bring him to the beach side, then only you can start the whatever it is. Okay, so scene safety is first. Or patient is electrocuted, you go there and touch him, you will also get electrocuted. So first you have to bring him out of the electrocute that wire with some with wooden log and all, then only you can start the treatment. Understood? That's scene safety. Then check for response. Check for the response. Check for the patient is whether responding or not. If it's not responding, okay, then call for help. Call the ambulance or the call other doctor if you know, whatever it is. Then after calling for help, then again try to talk to the patient. The patient is talking. Hello, hello, who are you? What's your name? I'm closing my eyes, but Kishan, I'm Kishan. Okay, that means patient is talking. Means you understand that his airway is intact, patent. Because when the air moves inside and out, your vocal cords move, that's how sound is produced. So if his sound is produced, means his airway is intact. Okay. So if airway is intact, my A is done. Assessment of airway is done. Then immediately I go for the no wasting time, taking rest in between. No, immediately to the second half of A, that is cervical spine movement restriction or protection. How you do that? By applying a cervical collar. Cervical collar. If you don't have cervical collar, what to do? You are in the roadside, you don't have anything, I'll tell you what to do. Okay, I'll do what to do. So if you think airway is fine, cervical spine is protected, then you go to breathing, second part. The patient is not talking. The patient is not talking, not responding. Instead, there are some signs like there is hurried breathing is there, increased like respiratory rate, or patient is using accessory muscles like sternocleidomastoid or intercostal muscles for breathing. There is okay exaggerated breathing like this means he's struggling to take breath. Okay, that's why use of accessory muscles. Third, he's snoring. He's snoring or gurgling. Some sound is there coming from the throat or hoarseness. Well, I can't. I'm not able to talk. This is called hoarseness. Or stridor. Stridor means see you are in the tube. It's squeezed, become narrowed. It's called stridor. Called stridor. Hoarseness means I am not able to talk. Called hoarseness of voice. Gurgling means some secretions are gone inside. It's gurgling. Snoring also same. If all these are suggestive of some airway obstruction is there. The severe airway obstruction, the air oxygen will not go inside, so patient will have cyanosis. You know what is cyanosis? These things are there means you will suspect airway problem. Airway problem. Then try to secure the airway. Try to secure the airway. Okay, by how you do? Initially, you secure the airway by clearing the. Try to open the nose or the mouth and clear all the clear secretions. There is a blood clots or any foreign body. Clear them. Try to clear them. Or sometimes tongue may be falling posteriorly. You may have to put the tongue like anteriorly. Okay, then the patient may become better. The airway may become better. Okay, so that's if still not there. There is no secretions or as such, but patients still continue to have airway problem. Then what you do is there is something called before see observe here. There is an order which what you do first check assess for the airway. You find problem in the airway. The next thing is the protection of the cervical spine, not treating the airway. Okay, you secure the airway, spine by criteria called mills. Mills means manual inline stabilization. The collar is not there, not available. What you can do is one person can hold the neck and head in one straight line like this from the head end. One can hold on the both the hands like this, can fix the head and neck so that it doesn't move like this, rotate doesn't not able to rotate. That's called mills, manual inline stabilization for cervical spine protection. Understood now? Then only you do maintain the airway. So first assess for airway, then cervical protection, then maintenance of airway. Hope this order is clear now. So maintenance of airway. How you do maintenance of airway? By initially you can try with two maneuvers. That's called, you just so many answered already. Called head tilt, chin lift maneuver, or also another is jaw thrust maneuver. These two maneuvers you use, okay, to so that the airway becomes patent. Sometimes it kinked and all. So with these two maneuvers, it may get patent. Then for the so far he was not getting oxygen properly, so his saturation may be little low. So you may put him on some oxygen. Okay, and then now airway secured. Airway secured. Then you can do the definite one. That is, you get a collar, Philadelphia collar. That's called semi-rigid cervical collar, also called Philadelphia collar. What's the difference from the normal collar is there's a hole in front, so that to secure the airway, if you require to do some tracheostomy and all, there is a hole here. Okay, that's called Philadelphia collar. Can you see? There's an opening here. Semi-rigid cervical collar. If it's available, you can put. Okay, if not, if the one should be this thing holding the neck and head in that position only till that. I did not understand salt. Okay, we'll come to that later at the end. Okay. Now after applying the collar, okay, now you have to do the. You can't keep it like that with the jaw thrust or this thing, because if you put back, you can again the airway may get compromised. So you have to do something definitive. Means for the time being, you can put a definitive airway in the like, you can do endotracheal intubation. You might have seen now for surgeries and all your maxillofacial surgeries and things, they do intubation. That you can do inline orotracheal intubation. Okay, or else you can, if there is intubation facilities are not there, then you can also do something called adjunct airway. Not definitive. Adjunct means for time being, to keep the airway patent, you can put something called oropharyngeal airway. Oro till the pharynx only. Definitive means it should pass the vocal cords into the after pharynx, larynx, and then into the trachea. Then it's called definitive airway. Adjunct means only from the mouth or the nose till the pharynx. It's not passing through the larynx. Hope it's clear. That's the difference between definitive airway and adjunct airway. You put adjunct airway when there is no apnea. Apnea means cessation of breathing, or saturation is more than 85%, or GCS. I'll tell what is GCS. Glasgow Coma Scale. If it's more than 8, you can put what is that, adjunct airway. The patient is unconscious, that is GCS is less than 8, or saturation even after giving oxygen is less than 85%, or patient is having apnea, then you have to do intubation in the form of definitive airway. Okay. Once you try intubating, not possible. Okay, then what you do is, next what you do is cricothyroidotomy. Cricothyroidotomy. Very, very important. These whatever I am marking now in the red, these are all questions. Okay. Even see, 3 people required. That was a question. I may not mention here, but if you read my notes, to do orotracheal intubation, how many people are required? 3 people. Why 3 people? One inline, that because we have not put the collar, so one has to hold the head and neck in position. Second one will be inserting the tube. Third one will be putting the trachea, pushing the trachea. It's called burp. Backward, upward, and right side pressure. Burp. BURP. Called BURP. Not required for you, but you can know. Backward, whatever this trachea is there now, it should be pushed backward, means posteriorly, upward, and little rightward. Pressure should be applied so that the vocal cords, that opening, will be easily seen for one who is putting the tube. So 3 people minimum required to do inline orotracheal intubation. If it's not possible, sometimes you are not able to put the tube inside, then what you have to do is cricothyroidotomy. What is cricothyroidotomy is, see here in the neck, okay, between the cricoid cartilage, all these things, anatomy you know very well. cricoid cartilage and the thyroid cartilage. This is the thyroid cartilage, this is a cricoid cartilage. In between that, there is a membrane like this, cricothyroid membrane. Okay, saponeurosis or membrane. You can just make the needle, you can just prick there. It will go into the airway. It will directly go into the airway. So from outside atmospheric air through the needle, it can go into directly into the airway. For time being, there is upper airway obstruction is there. Upper airway obstruction is, so air is not able to enter into the trachea. So what you can do is just put a needle, wide bore needle directly. No need of anesthesia, nothing. Patient is already struggling. You take a wide bore needle and immediately put it there. Just a cricoid you can palpate, thyroid cartilage you can palpate. In between that, whatever the space is there, immediately put a needle there. So whatever the atmospheric air is there, it will be sucked inside. Airway like protected. Hope it's clear. That's for time being. That's called needle cricothyroidotomy. If in hospital, patient is in hospital, you can also go surgical cricothyroidotomy using a surgical blade. You can do open there in the cricothyroid membrane, then put a proper wide bore cannula like this. That's called surgical cricothyroidotomy. That's also possible. Hope it's clear how to secure the airway so far. Okay. Hope it's clear. So I was telling the algorithm is first airway assessment. Airway assessment first. Airway assessment. After assessment, immediately you don't manage. Second thing is cervical spine protection. Third thing only managing of airway. So this is the order. Remember this. Okay. Now some questions we'll have. Okay. Head tilt, chin lift, you understood. Dental ke according padaiye. Dental surgery you have separately. Ayushi, madam will teach you. This is general surgery, and this is not my own. As per the protocol I am teaching, so we have to go by this. I didn't understand salt. Salt is S for sorting. Sushma, S for sorting out the patient by triage. A means assessing. Assessing means I told whether it's any life-threatening injuries are there or not. Okay, and L for giving life-saving treatment. T for definitive treatment or transportation. That's salt. Not very important, just for you to remember. I'll explain again. One, definitive and adjunct. Okay, definitive and adjunct. You want to repeat? Okay. Definitive means in airway. Airway starts from nose till the bronchioles, right? The lungs. So you put a tube or something, some instrument from the mouth, from the nose, goes only till the pharynx. Goes only till the pharynx. Then it's called adjunct airway. Oropharyngeal airway. See, oropharyngeal. I'll show you now. Next, anyway, I'm coming. See, we are coming to that one anyway. See, this is a very short one, small one. See here. It can only till the pharynx can go. If the patient is having some problem in the nose or anything, can use adjunct airway. Definitive airway means from the nose or from the mouth, it should go from all the way to from pharynx, laryngeal opening is there, no? It should cross that and go into the trachea like this. Then it's called definitive airway. Hope it's clear. We are anyway going to discuss that. Please explain on. No, sir, in children, we can't do what to do. Burp full form, sir. Burp full form I already told. Backward, upward, right side, pressure. Burp full form. Yes, sir. When do we use Glasgow comb? We are coming to Bishal. We are coming to that. Okay. We use it in ABCD. But that's thyroid membrane, sir. Cricothyroidotomy is done below the thyroid clause. Yes, I am right. Yes. Crico. I told. Yeah. This cricothyroid membrane. Cricothyroid membrane. Okay, just to show you in this thing, I told that way. But between the thyroid cartilage, you can feel no below that, which is first prominent tracheal ring is there. No, that is cricoid. This between there is a small gap is there. That is a cricothyroid membrane. But just you can't do all those things. Just to show you, just to explain, I told you that between the thyroid and in the neck there is a space is there. There you just put a needle. This protocol. In this protocol, we are this thing. Okay, fine. So now coming to the two types of airway, that is definitive and adjunct airway. Definitive airway, it can be of two types. I told you, one is endotracheal intubation, that is oral you can do or nasal you can do. Endotracheal intubation using a this is called ET tube, endotracheal endotracheal intubation tube, ET tube. It's from the mouth you can put or from the nose you can put. It will go directly into the trachea. Okay. Second is surgically also you can do definitive airway, that is using tracheostomy, directly trachea or second to third tracheal ring can be opened up and put a this is a tracheostomy tube, right? Tracheostomy tube you can directly put the trachea, so air is directly going into the lungs. Or you can also do cricothyroidotomy, just like we mentioned. It can be done needle or it can be done using surgically also. Okay? So these are the definitive airways. Whereas adjunct means kind of temporary. Means oropharyngeal from the mouth to the till the pharynx, or nasopharyngeal from the nose to the pharynx, or laryngeal mask airway just covers the larynx. It doesn't go inside the passes through the larynx. Over the larynx it covers. See, this is called laryngeal mask airway. In the pediatric center we use this. This mask covers the larynx and you give using umbo bag, umbo bag, anything. All these what are the tubes are there, will be connected to the umbo machine, bag and mask. You pump like this, air will go inside. That's the adjunct airway and definitive airway. Not so important for you, will not go into all the details. One question has been asked particularly for you in maxillofacial trauma. Okay, when the entire face is shattered, there is maxilla is fractured, mandible is fractured, there is a bleeding from the mouth and all. In such a scenario, okay, this what to say, intubation is contraindicated. You don't do intubation because it may further injure the further it may aggravate the injuries. Whether the nasal bone fractures are there or the airway compromises, it may further aggravate. So you straight away, if there is any facial trauma, in the question it's given that patient has sustained facial trauma or maxillofacial injury, then straight away you do needle cricothyroidotomy, and further you can do surgical cricothyroidotomy or tracheostomy. Hope this one scenario is very important. Patient has come with polytrauma, all those this, and they'll give you patient is in shock, this, that, and all. And one somewhere they'll mention that patient also sustained facial trauma or in the form of maxillofacial fracture, something they'll mention. Then they'll how do you secure the airway? Not intubation, but by tracheostomy or cricothyroidotomy. Hope it's clear. You have to use birth while intubation. Harshita, while doing intubations, you have to push the trachea, or otherwise trachea will move like this when you put the tube. So you have to keep it in position by doing this maneuver. Okay, so that maneuver is called birth. Backward means just push like this, and upward just push upward, a little towards the right side. Called birth, tracheostomy. So then after I told you that sequence also, airway assessment and cervical spine protection, then airway management. After doing all this, then you come for breathing. In breathing, mainly I told you should look for how is the breathing pattern, whether the patient is taking breath adequately, quantity as well as the rate. Rate is also adequate, or if it's too much rate, too less rate, or any irregular breathing pattern is there. You check all those things. B. In breathing, there could be some problems, right? Like we immediately life-threatening, there are two. That is tension pneumothorax or open pneumothorax. So how do you assess for this? How do you assess? Because it's inside the lungs or inside the thoracic cavity. You will not come to know from outside. So there are some certain signs and symptoms which will tell you that patient is having pneumothorax or hemothorax, some problem inside the lungs. How do you know? What are the signs and symptoms? Any questions? In maxillofacial trauma again, sir. Anyway, Banushree, we are going, this is just a overall picture I am giving you. We are separately talking about the maxillofacial trauma in detail. That time I'll explain once again, okay? Here I just want to tell that any facial trauma, for now you remember, any facial trauma involving any fracture or any upper airway problem, you don't try to secure the airway from nose or mouth. Instead, downwards, where there is a fresh area is there, like a cricothyroid, cricohyoid membrane, or tracheostomy. You can do all those things, because if there are injury, in putting the tube, you may further increase the injury. That is the concept here. Hope it's clear. Yes, cricothyroidectomy, nahi, cricothyroidotomy. It's a yes. It's a definitive, Srija. It's a definitive. Okay, you can keep it, but the flow is very less. So later on, once the patient is stabilized, you can do the tracheostomy so that you can keep it in place. In maxillofacial trauma, we have to give cricothyroidotomy or tracheostomy if both options come. See, in tracheostomy takes time. To do tracheostomy, it takes time. So immediately, life saving is cricothyroidotomy. Then I told you over that then you can do tracheostomy, then remove this cricothyroidotomy. Hope it's clear. Sir, tracheostomy is same as surgical crico. No, 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 no. Tracheostomy is different. Cricothyroidotomy is different. All these not given in notes. Get notes after class. Yes. Do we have to make our notes? Can you please? Okay, now listen to the class, then we'll talk about the notes later. Okay. Okay, now coming to the how do you assess the breathing? So first thing is simple pneumothorax. Simple pneumothorax means what? There is a pneumothorax, but it's not hurting him so much. Okay, so okay, Nikita, we want me to go a little slowly. Okay, but too much to cover in trauma. Ayush thinks Ayush dental MDS में आता है उन्हीं पढ़ाई. All these are from your entrance exams only, like from previous year questions only. I'm telling. I'm not telling anything more. I told in the beginning only. What is really required for you, I'll tell. Nothing else. Emergency tracheostomy can be used. Yes, if you have, if you think, yes, I'll tell you. In the burns and all, we do emergency tracheostomy and all. Okay, but in airway obstruction, to do tracheostomy, minimum 1-2 minutes is required, and tracheostomy set is also immediately not available, the tube and all. So emergency tracheostomy can be done. We do, but in a trauma scenario, first thing what we do, because just one needle is enough to do the cricothyroidotomy. Then the tracheostomy you can do little later. When to use jaw thrust and when to use chin lift maneuver. See, the best one among those two is jaw thrust. Jaw thrust you can do anytime, and both can be done. It's not like when to do jaw thrust, when to do chin lift. Both can be done, but in that also preferred one is the jaw thrust one. Okay. So coming to breathing, simple pneumothorax. In there are four conditions. We'll see what the difference in each. Simple pneumothorax and tension pneumothorax, and massive hemothorax and simple hemothorax. Respiratory rate. There is a see, breathing is happening like this. Whenever there is some obstruction in the lungs, what will happen to the respiratory rate? It will increase. In the lungs, there a little bit air is accumulating between the lungs and the pleura, so it's not disturbing much. But yes, there is some obstruction, so respiratory rate will slightly increase to compensate the volume. Earlier lungs was expanding this much. Okay, so the respiratory rate was 14 to 16. Now the lung is able to expand only this much because air is filled outside that. So to compensate for the volume, it has to increase more time. It has to contract more times. So respiratory rate increase from normal 14 to 22, slightly higher 22 to 24. In case of tension pneumothorax, entire lung is collapsed, so it has to pump the air. Now it has to pump many times. Okay, so respiratory rate will be very high in case of tension pneumothorax. Coming to hemothorax and massive and simple hemothorax, same, just like air, there it is blood is covering in the pleura around the lungs. So entirely covered by blood means lungs will shrink like this in the middle. So respiratory rate will increase. In the simple hemothorax, where some blood is collected, respiratory rate will be slightly higher. Hope it's clear. What will happen to the blood pressure? In simple hemothorax, it will be normal. The tension pneumothorax, because there's obstruction to the blood flow. Okay, so there will be hypotension. In the massive hemothorax also, almost all the blood volume is getting lost into the pleura. Volume is not coming in the vessel. blood volume is getting leaked into the pleura. It's not coming into the circulation. Okay, so here also BP will fall. And in simple hemothorax, only little bit blood, maybe 50 ml, 100 ml is lost. So it will not hamper the blood pressures. JVP, what will happen to the jugular venous pressure? The simple pneumothorax, everything is maintained, it's normal. The tension pneumothorax will be raised. The massive hemothorax, it will be low because volume is also low. All these things, what is JVP, all those things you will learn in medicine. Okay, I'll not go into the details. And in simple hemothorax, it's maintained. What's important for us as a clinician is this next one, what I'm telling, percussion. On percussion, it's called percussion, you know this. You just tap over your thorax and see. Percussion. On percussion, if there is air is there, it will be heard as hyper resonant or resonant usually. If full of air, no solid, then it will be hyper resonant. Okay? And if there is a liquid or some solid thing is there inside the thorax, it will be heard as dull. The liquid or solid is there, dull. If air is there, it's resonant. Usually, it's a combination of both lungs, which is solid, and air inside. So it will be resonant. But in tension pneumothorax, what happens? Entire pleura or entire lung thoracic cavity is covered by only air. Lung tissue is fully collapsed like this. So when you tap, everywhere it will be fully resonant. It's called hyper resonant. Okay? So that's the difference. Whether to know whether it's you are dealing with a case of massive hemothorax or pneumothorax, tension pneumothorax. You can differentiate just by percussion. When you percuss, if it's a hyper resonant note, then it is tension pneumothorax or pneumothorax. Or if when you percuss, if it's a dull note, then it is a hemothorax, that is blood. Breath sound, you auscultate, you take your stethoscope and auscultate. When you auscultate, you can't hear the breath sounds at all. That means lungs is fully collapsed. It can't breathe only. It cannot like inhalation, exhalation not happening. So can you hear the breath sounds? No. Tension pneumothorax or massive hemothorax, breath sounds will be either absent or almost decreased. Whereas in simple pneumothorax or simple hemothorax, it will be just decreased, not completely absent. Trachea, what happens to the trachea? Trachea, in the simple pneumothorax or simple hemothorax, it will be central, normal, like this. Whereas in tension pneumothorax, what happens is a lot of tension is building up on my left side. Okay, so air is gushing inside and creating massive pressure. So my trachea and some mediastinal structure, whatever is there in the middle, it will push to the outside. Sorry, to the opposite side. To the right. That's called tension. See, this is a room where 5 people can live. If 5 more people come here, what will happen to the native 5 people? They'll be compressed, right? They'll be compressed. So, and they may be pushed to one side also. Maybe they may be, if 5 more people comes, they may be pushed outside the window also. That's how the trachea or the mediastinal structures, whatever is there, since air is entering the left side continuously, due to built up pressure, whatever the trachea is there, it can move to the opposite side. This is a very, very important sign. Many questions will be based on this one point. That is trachea shifting to opposite side. Okay, it's a sign of tension pneumothorax. Please underline this and put 5 stars to this. So important this is. If you suspect simple pneumothorax, what you do? To confirm, you get a chest X-ray. In that there is a that patch will be seen. You confirm simple pneumothorax. When you suspect clinically tension pneumothorax, no test, no chest X-ray, nothing. It's a life-threatening. We discussed, no? If it's a tension pneumothorax, open pneumothorax, it's immediately life-threatening. So what you have to do is immediately put a needle. Where you put? In the 5th intercostal. We'll discuss that later. In the 5th intercostal space, you put a needle. Okay, all the air will be passed out, so there will be relief inside. Okay, that's the treatment for tension pneumothorax initially. Then massive hemothorax, it's not immediately life threatening. Okay, you have some time, you can do you can put a tube there. I see it called intercostal drainage. You can bring out all the blood, patient will feel better. Okay, that's the difference between all the 4 conditions. We'll go on so many conditions, then you will understand better. So this is the pictorial diagram representation of all the 3 types of pneumothorax. It can be closed pneumothorax, open pneumothorax, or tension pneumothorax. 3 types. Closed means from outside no injury, because of some blunt injury or something, I have fell down to the road. Outside no injuries, but inside my one bronchiole is ruptured. So whatever the air I am taking, it's getting leaked there from the lungs inside the pleura only. Pleura, for example, see this pleura, okay, and inside there is a lungs is there, right? So there is a leak here. Whatever the air I am taking, it's getting leaked from here into the pleura. So it's a uh, closed one. It's a closed pneumothorax. Open pneumothorax means there is a wound. Wound is there from the atmospheric air is directly entering through that wound into the pleura, sucking inside the thorax. There is a negative pressure is there that will suck the air inside, suck the air. So all the atmospheric air will be going inside. This is called open pneumothorax. Tension pneumothorax, either closed or open, there's lot of pressure inside because of continuous air gushing inside. That will see pushed. See, normally trachea should be central, right? Pushed to the opposite side. Heart should be there in the middle. It's pushed to the opposite side. That's called mediastinal shift. Trachea is shifted to the opposite side. Okay, tension pneumothorax. Okay, see, I'll show you some X-rays. You'll understand better. Now you tell me. I'll not. So you are understood here. So now you tell me in this X-rays what's shown. The X-ray 1. So X-ray 1, what is there? X-ray 2, what is there? You tell me. Till then, I'll go through doubts. Musa is asking, why switching from cricothyroidotomy to tracheostomy? Yeah, cricothyroidotomy you do a very small hole, right? You can't be kept for longer. You need a wide bore this thing tube. So that's why you shift to tracheostomy. Is it just for me or voice is breaking? No voice break. Okay. RR. Okay. Respiratory rate. RR means respiratory rate. 22 cycles per minute, 24 cycles per minute. Per minute, how many times we inhale, exhale? That's called respiratory rate. Saptarshi Muzumdar, I guess. What is 20? VP and JVP. One is tension pneumothorax. Saurav is telling. First one is tension pneumothorax. Priyanka is telling. Very good. Very good. Apurva is right. Very good. Prati is telling very good. Very good. Triveni, very good. Excellent. Yeah, she is telling better answer. Who is that? Harshita is telling better answer. Left tension pneumothorax. Very good. Excellent. If you understand this much, enough. See, sometimes I go little faster, means we are going to discuss later on in detail. That's why that time I will go little faster. Again, I'll discuss. Okay, don't worry. Just like already someone mentioned, we know we have been doing this for so many years now. We know what is very important for the students, which pace we have to teach, and where we have to explain more, where we have to rush, everything. Okay, so we'll do as per your needs only. Not that I know surgery, I'll show it off. No, not that way. I'm here to help you ease your preparations. So if I'm telling going little faster means just understand that this concept is going to come again and again, where it will be discussed in detail. Okay, don't like in one slide only we can't learn everything all at once. Hope it's clear. So this is tension pneumothorax. See, this is a cardiac shadow, the heart. It should have been there in the center like this. Just push to the complete to the right side. And normal lungs is like this. See, this is almost the normal lungs. If you know the normal lungs, then you will understand everything else. Normal chest X-ray is like this. See, trachea. This is the central trachea is there. Okay, then you have the cardiac shadow is in the center like this. Okay, and see, some air is also there. Some solid tissue that some white tissues. White is lungs. Black, what you can see is air inside. So usually it's a mixture of white and black. Lung shadows like this, both the sides. See, but here what has happened? See, in this image, the left side is completely black. There is no white tissue, this thing at lung tissue at all. uh, lung is completely collapsed. Fully, it's accumulated by air. And hard shadow should have been there in the center. It's pushed to the, because of the pressure, it's pushed to the opposite side, to the right side. Trachea should have been center here. Come here, see, can you see the air shadow here? Trachea. Okay, trachea is coming here, see, two bronchus, right bronchus, left bronchus. Can you see? Okay, that's called tension pneumothorax. Now tell what is happening here. Here you can see now, you can understand better now. It's not dextrocardia, Asamusa. Yeah, you are right. It's not dextrocardia. Whatever the heart is there, it's pushed towards the right side. Here you can see this is normal. Left side is normal. Heart is there, and lung shadows are there, and air is there, that is black. But on the right side, what has happened? See, only in the middle part some lung tissue is there. Outside only black. Black means air. Okay, so it's a pneumothorax, presence of air in the thoracic cavity like this. This is pneumothorax, but it's not tension pneumothorax. See, trachea is there in the center, trachea is there in the central, and heart is there in the middle only. So this is not, this is simple pneumothorax. The pneumothorax, but it's not causing any pressure inside. And the lungs is slightly compressed. Simple pneumothorax. Clear? Yes, Vidhi is right. 2 is simple pneumothorax. Very good. All of you written correctly. Very good. Right lung collapse. Excellent, Bindu. Very good. She observed it rightly. The right lung has been collapsed because of the presence of air inside the pleura. Now tell me what is this? Here now. Now you tell me. Now 3 and 4. Now tell me. What do you understand? 3 and 4. Very good. Saptarshi is correct. Very good. Very good. Pinu is right. Very good. Sadhu is telling pneumonia. Okay. Is normal. Very good. Purva is telling. So this is not actually, in fourth, what you're seeing is, this is white. Completely white means is some liquid is there. What is there? What it could be liquid means blood or pleural effusion. That's correct actually. Very good. Aditi is right. This is pleural effusion. Whatever the white thing, what you can see here, like this, some white thing is there like this. Huh? So whatever this effusion means, some collection, some liquid collection is there. Anything, liquid can be anything. Like she told, it's correct. This is left hemothorax. If I give a history, patient sustained a chest injury, then whatever the liquid collection is, can be blood. So hemothorax. Patient is having tuberculosis or pneumonia, and patient is having a this like this, then it could be pleural effusion or chylothorax or pyothorax. It can be pus, anything, any liquid. Understand that much. In case of trauma, what we are suspecting is blood. So it's hemothorax. Hemothorax. Okay, very good. Now tell me, what is this? Now, if you understood everything, now tell me what is 5 and 6. What is 5 and 6? You tell this clear. Saptarshi, sir, how do you know it's pleural effusion or hemothorax? Everything, any liquid collection is pleural effusion. Under pleural effusion, you have pyothorax if it's pus, or what is that? Hemothorax if it's blood, or just what is that? Chylothorax if chyle or lymph is there, like that. Depending on which fluid, you have different names for pleural effusion. Hope it's clear, Saptarshi. Good question. Yes, in pleural effusion, costochondral angle is faded. Correct, Bindu. Okay, we look at the costochondral angle. See here, this is the costo on the bone. Costophrenic, not costochondral. Oh, sorry, costophrenic angle. From this is diaphragm. Diaphragm, and this is the ribs. This ring, this angle should be clear. Air should be seen black. then it's normal. Blunted, see, you can't see the left costophrenic angle. Some liquid is there. Something is collected there. See, all the here, all the places, costophrenic angle is acute like this. Then it's normal. See? But here, costophrenic angle is not seen at all. That means some fluid is collected there. So 5 is, somebody is telling 5 is simple, 5 is pneumothorax, correct? Any better answers? 5, 6 is, the 5 is bilateral pneumothorax. See, here also pneumothorax is there. Here also pneumothorax is there. You can see lung tissue like this. Here also lung tissue you can see. Bilateral pneumothorax is there. 5. 6, very good. 6 is, this is a pneumothorax. Okay. Right sided pneumothorax. No tension and all. So trachea central, how do you say there's a tension pneumothorax on X-ray? There's a trachea is deviated to the opposite side, or the hard shadow is shifted to the opposite side, and the entire the one side is completely air filled or hyperlucent, means fully black. Fully black. See this? Fully black, right? Fully black. No white patches at all in this. This is tension pneumothorax. This one question will be definitely there. There in the case format or X-ray or something. Definitely one question, please write down. Out of 10 surgery question, one question will be definitely on tension pneumothorax. Any exam, any, between NEET PG or MDS entrance, FMG entrance, any entrance, one question invariably and inevitably from tension pneumothorax. Please take it out from me. Okay. So one answer you already got before even attempting the exam. You got one answer right. Okay, next, coming to one last topic, then we'll go take a break. Okay, take a break before circulation. That is, okay, now if there's air or blood, how do you take it out? Okay, for pneumothorax, you can put a needle first. Okay, when the air little the goes out and the tension is relieved, then you have to do something definitive. That is called intercostal drainage. You put a intercostal tube. Where do you put? Called triangle of safety. Somebody already answered. It's called triangle of safety. Means in the chest, like so many vital structures are there. You can't put the tube where and whenever you want. There are some certain areas where there are no neurovascular bundles or any vital organs. Okay, that's called triangle of safety. Triangle of safety is this. This is triangle of safety. Okay, see, this is the chest. This is the back. In between, in the axilla here, you have a triangle of safety bounded by anteriorly. This is anteriorly by the muscle, pectoralis major muscle. Anteriorly, laterally there is another muscle. Posteriorly is by another muscle, latissimus dorsi. Lats, what you call lats? No, latissimus dorsi. And in the base, this triangle's base is formed by a straight line drawn, straight line with the nipple. You take a straight line from the nipple, wherever it goes extends outwards, no? That is the base of the triangle. This triangle, there is no any vital structures, no neurovascular bundles or lungs, tissue, nothing. So here you can put the tube safely inside. So you can insert the tube. Okay, tube will be put like this. See, for example, see, this is a tube, intercostal drain will be put. See, there is a air collection here. So you put a tube to pierce the muscle in between the ribs and put a tube inside. You pierce the pleura and put a tube inside. All the air, whatever is collected here, it will come outside to this, and it will be collected in a water seal. You have to connect it like this. Keep it open, the tube from out, atmospheric air will be sucked inside because pressure inside is low. Any air will move from a higher pressure to lower pressure. You should always connect it into a other density, that is water. Water seal. The water seal is there, very important. No questions as such, but you should know this concept. All the air will come and move into the water. So air bubbles you can see, or air column moving in like this you can see. So one more question is asked in this particular concept. One more question is asked: where you exactly put the tube? Okay, in the triangle of safety. Okay, triangle of safety is between the second to fifth intercostal space. Second to fifth intercostal space, the axilla. Okay, anteriorly by the pectoralis major muscle, posteriorly by the latissimus dorsi muscle, and base is formed by the line extended from the nipple. So there is a big triangle is there. In the mid axillary line, the axilla, anterior axillary line, whatever fold is there, a posterior axillary line and mid axillary line. The middle of the triangle here, middle of the triangle you put the tube. That also where there are ribs are there, no? Ribs are there. Where to put? In the upper part of the rib or lower part of the rib? The question answer is the upper part of the rib, because in the lower part of the rib there are neurovascular bundles. Between the see there are two ribs are there like this. This is one rib. This is another rib. Just below the rib passes the nerves, veins, artery, and all like this. Lower down is free. So you have to put in the lower space. The lower space. That is, see, this is the intercostal space between the two ribs. One rib, another rib. You should not put just below the rib. In fact, you can put just above the ribs. Just above the rib. See, it's safe here. Understood? So how the question options can be like this. ICD is inserted in the fifth intercostal space. Okay, fifth intercostal space it's, or fourth or fifth intercostal space it's put. Options can be the lower part of the intercostal space. One option can be there. Another can be the upper border of the rib. Both are right. It can be put in the upper border of the rib. See, this is the rib. The rib. You can put it in the upper border of the rib like this. You can't put in the lower border of the rib because there is a neurovascular bundle. Or you can put it in the lower part of the intercostal space. One means the same, one another same. This is the intercostal space between the two ribs. What of space is there? No, that space is called intercostal space. In the lower part of the intercostal space, you can put the upper part of the intercostal space. There are neurovascular bundles. Means the same. Okay, both are means the same. Is a lower part of the intercostal space and upper border of the rib. Both are the same space they're referring to. The options they can give anyway. Let's say about the intercostal drainage. Triangle of safety, border important, and where do you put the tube is important, and which part of the ribs where do you put. So you need a much needed break for going to circulation. Now it's 7:10 I think. We'll take a 10 minutes break. You take a water and take a come fresh and come back. Then we'll discuss circulation, and this is simple ones. Circulation we'll discuss. Some head injury and all. GCS we'll discuss, and then we'll discuss the MCQs before leaving today to make you understand better. To revise the things, I have some 20 very interesting MCQs for you at the end of the class. We'll discuss that and we'll finish today's class. Is that okay? Now it's 7:10. We'll join back at 7:20 exactly. Okay. Take a short break. Till then, any doubts are there? Please take a break. Doubts, meanwhile, I'll try to solve. Okay. That's most of the question in your exams will be based on tension pneumothorax only. Okay. Okay, fine. Come back at 7:20.